Over the past 4 weeks, we have looked at the molecular and genetic basis of cancer, what happens inside the cell. Now, in the next 2 weeks, we shall look at the human side of dealing with cancer.
Here at the University of Bath, we're very active in cancer research in collaboration with the local hospital. And we have a group called Cancer Research at Bath, which looks to bring research really right from the laboratory into the clinic, what we call translational research. And the way that clinical trials tend to go in cancer and oncology is that products and drugs are developed in the laboratory and then tested and really looked at getting the right dose and the safety initially, and then whether they work, whether they're effective in particular tumour types. And then finally into a phase of trials where they're compared against their standard treatment, or if there's no standard treatment, against a placebo. And the sort of topics that we're looking at, particularly in research at the moment, are really about individualising treatment for a patient. So we've heard something about targeted therapies, but also there's tests being developed to predict response to chemotherapy or predict benefit from treatment. And then also imaging techniques which might better help us assess how treatments are working more quickly. And of course there are developments as well in new technologies, both in surgical techniques and in radiotherapy treatment, which is still very active, as well as just the drug therapies that we've heard about. So there's lots happening in cancer research, and as I say, in Bath here we're at the forefront of some of the clinical trials.
This is what happens when you've been first diagnosed with cancer and you walk in for your first consultation with your medical oncologist. We have made a mock-up scenario of a typical consultation.
So how are things after the operation?
I think I'm recovering well. The wound's looking good, and the surgeon seemed very happy with me.
Yeah, no, they do. I've spoken with them already. We had a meeting the other day, and they explained what they'd found, and they were really happy that, as far as we know, all the tumour's been removed, and everything went well from that side of things. And the reason for meeting today is really to talk about what we do next, if there's any more treatment that's required. Did they explain to you what they'd found at the operation?
Yes, they told me that they'd removed a cancer that I think was a couple of centimetres. That one of the lymph nodes that they'd taken out of my armpit had some cancer in it, but I think the others were all clear. I think they also said that it was actually quite an aggressive sort of cancer. Is that right?
No, that's right. I mean, that's what the things that we look at when we look at the specimen or the tumour that's been taken out. Firstly is the size of the tumour. And yours was 2.5 centimetres, which was relatively small compared with some breast cancers that we see.
Okay.
And then we look at the grade or the measure of aggressiveness of the cancer under the microscope. And that gives some idea about how the cancer cells have a potential to spread. It doesn't mean that they have spread, but the more aggressive ones, the grade 3 as we call them, like yours, perhaps do have more potential to spread. So it might make us more inclined then to give you some more treatment as a reassurance after the operation.
Right.
The next thing we look at is the lymph nodes, and as you say, that one of those was involved. They took away 12 glands, and the other 11 were all clear, which is obviously very reassuring.
Yes.
The lymph nodes often act like a chain, so if the first one's involved and then the next 11 are clear, that's usually reassuring that it hasn't gone any further. But of course, again, the fact that it had moved out into the lymph node does add weight to the idea that we might want to give some more treatment, and by that I'm really talking about chemotherapy. And the other thing we look at is the receptor status, and by that I'm talking about proteins on the surface of the cancer cells. So you may have heard about drugs called tamoxifen, and there's various other ones. And some cancers, some breast cancers, have hormone receptors on, or hormone-sensitive proteins on the surface. Yours didn't. Yours was hormone negative, which means that you don't need the tamoxifen drug.
I won't need to take that at all.
That's right,
Okay.
yeah. But there was another receptor, something called a HER2 receptor, which was expressed on your cells. And this is a more unusual one. You may have heard of a drug called Herceptin.
No, I think I have. There was quite a bit about it in the news a few years ago. I think it's quite an expensive drug. Is that right?
That's right, yes. And it's made a big difference into how we treat these types of cancer. Probably only 1 in 5 ladies with breast cancer have this particular receptor on there. But for those people, the Herceptin drug makes a big difference in terms of reducing the risk of the cancer coming back.
Okay, good.
So based on what we've said, I would recommend really that we think about having both chemotherapy and Herceptin.
Both of them?
That's right, yeah. And it's a long course of treatment. We're looking at effectively a year or just over.
A whole year?
That's right. The chemotherapy itself is given every 3 weeks, and for 6 lots. So we're looking at 18 weeks of chemotherapy, but the Herceptin carries on for a whole year.
Will I feel unwell during that time?
During the chemotherapy, you will get side effects, and we'll talk about those in more detail later, but they're likely to include tiredness, nausea, hair loss.
Hair loss.
Yeah.
Okay.
And a risk of infection, which is the one that we get most concerned about.
So do I need to sort of stay away from people? Do I need to keep indoors during that time?
No, I don't think you need to do that. Okay. Because your blood cells, your white blood cells, which fight infection, will drop. And that's normal and they recover. But while they're low, it means that you're more prone to getting an infection. But the Herceptin, I think you will tolerate very well. Most people get very few side effects with the Herceptin. You're likely to be able to function pretty much normally and go back to work and do all those things that you would normally do.
Okay.
It's only during the chemotherapy that I would expect you to feel unwell. And that wouldn't even be for all that time.
Okay. Okay. And so if I decide to go ahead with the treatment and I go through a whole year of treatment, is there still a chance that it might come back even after going through all of that?
There is. I mean, we can never say that it would never come back. We know already that it's been removed as far as we know, and there's more chance that it won't come back than it will. And by having the chemotherapy and the Herceptin, we make that chance more likely that it won't come back. It's almost like an insurance policy to try and prevent this cancer from returning. And there's no test that we have at the moment that can tell us that. So what we have to do is we have to make an assessment of what we think the risks are of the treatment and the benefits. And we offer the treatment to the people that we think would benefit most. But on an individual basis, we don't know whether your cancer would ever come back even if we did nothing. But we know by having this treatment, we can reduce that risk down substantially. And for you and what we know about your cancer and your age, we know that the benefits of the Herceptin and chemotherapy would outweigh the risks, and there's more to be gained than there might be for some other patients.
Okay, good. So this case that we've just looked at would be typical of the sort of consultation that we as oncologists might have with our patients. We've used breast cancer as an example, but actually the consultation and conversation would be very similar for all sorts of different types of cancer, although the specific drugs that we might be discussing would clearly vary. We use the term chemotherapy to describe a number of different drugs, all of which act in various different ways to kill cells that divide and grow quickly. As we've learnt more over the years about different types of cancer and which cancers respond better to different drugs, we've come up with different combinations which are better for certain tumours and rather than others. This means that the chemotherapy that is being given for example, colonic cancer could be completely different to that was being prescribed for ovarian cancer. So you'll be hearing about new targeted agents which have been developed to look at particular problems or pathways within different cancer cells which can add to the benefit of the chemotherapy that we already use. These can be used either in combination or in sequence with chemotherapy to improve the outcomes that we can expect for our patients.